Hello, everyone. It's an absolute pleasure to be here with you virtually, and I'm really excited about today's conference topic because it really gets at our fundamental assumptions about teaching and learning. We're asking ourselves, is learning something that is informative, literally lifting off the top of a container and pouring information in? Or is it a transformative process? We're asking ourselves, what is the role of the teacher? Are they a content expert, a guide, a coach, a co-learner? We're asking ourselves what motivates student learning. And I'm so excited to be exploring some of these issues during the conference and during my talk today. The talk will be about general principles of medical education, but particularly about sort of a case example of an innovation that we have at my home institution at Harvard Medical School called the Cambridge Integrated Clerkship. So first, I'll start off with a definition of what I mean when I say a longitudinal integrated clerkship, which our model is one of. And this really is about learning the core skills of doctoring over time across venues of care by having real relationships with patients and faculty mentors. So an LIC is the central element of clinical education whereby students participate actively in the comprehensive care of patients over time. And they also participate in continuous learning with faculty preceptors who are the patient's clinicians. So it's really a triad. And they meet the majority of the year's core clinical competencies across multiple disciplines simultaneously. And this is in contrast to traditional block rotations where students would move from one subject to the other, largely on inpatient services. This is a recent group of our students with Dave Hirsch, the program director, down on the lower right. I know he looks like a student, but he's actually only a few years younger than I am. And I'm just showing you this because in most institutions, LICs are smaller cohorts within a larger medical school. We have 160 students in our medical school, but this is the only integrated clerkship that we have. So the agenda for today's talk is first, what is the rationale for making change? Change is hard. What is the rationale for doing things differently with this form of clerkship? Then I'll tell you a little bit about our clerkship, and finally we'll end with some challenges and lessons learned from our experience. So in terms of making change, I remember my grandpa would say, if it ain't broke, don't fix it. But things really are broke, and we want to make sure that we are able to match our educational designs with the needs of the 21st century healthcare system. We also want to address some of the declines that we've seen over and over in empathy and patient-centeredness and ethical sensibility among especially clinical medical students. And finally, we want to make sure that our educational models are undergirded by good sort of educational design and informed by the learning scientists. So in terms of the first one, we, in the States at least, and I think probably in many first world locations, have seen really dramatic changes in the context of care over the last several decades. On the inpatient units, we now have patients who have hyperacute illnesses who stay for very short periods of time. And from the moment people are admitted, we're already talking about their discharges. So our students will meet their patients when they're very sick. They don't see them getting sick over time. They don't see them getting better. And they don't know them in their life context. Years ago, even when I trained, patients stayed for much longer, and we could get to know them better. We could get to know their families. We now have hospitalists taking care of patients on our inpatient services, and they do a great job, but they're disconnected from the patient's home life and outpatient care. Resident duty hour limits also can fragment care. And students also don't really get to know their teachers over time. So these are some changes in the inpatient setting where much of education happens that affect student learning. There's lack of continuity, lack of longitudinal relationships with experienced faculty, as I just said, but also recurrent, rapid, and unpredictable change in learners' roles that learners have to adapt to. In terms of number 2, addressing the hidden curriculum and ethical erosion, I'll just speak a little bit about that. As we well know, learning to be a physician is a process of socialization. We learn by role modeling, by seeing how our senior physicians treat patients, speak to them. We also learn how to be a doctor by seeing how our senior clinicians treat nurses and other members of the healthcare team. We listen to their jokes. We sort of suss out the difference between sort of subcontext. So you learn how to behave on your surgery rotation. When you're rounding, you very quickly, and please, if there are surgeons in the audience, I know this is a generalization, but you ask about postoperative pain, you press the belly, you may ask a few questions, but rounds tend to be quicker, which may be different than pediatrics or other services. And people sometimes say that the best medical students are kind of chameleons, learning the customs and rituals of any given service. And many of them know that their grade has much more to do with how well they adapt than their medical knowledge and skills. And many, many studies have shown declines over the clinical year in some of the more humanistic aspects of medical education. And finally, we want to inform our learning by the learning sciences. And just a couple of points on this. This is a great book called Make It Stick, and it's about how to help learners have deep learning that they retain. And there are 2 sort of techniques that really help with this. One is spaced learning, and that's just sort of the repetition of key concepts over time. And the other one is something called interleaving, which is actually having learners learn different but related subjects simultaneously. And this second sort of technique really feels counterproductive to people. We've all had the experience of cramming for an exam in one subject, really stuffing a lot of information into our heads, taking the exam, sometimes doing very, very well, and then forgetting everything you learned a couple of weeks later. Students who learn in an interleaved manner may really feel at a loss, like they're not mastering any subject. And it can be disconcerting because many of the students have done well through the cramming method. But what we now understand is it's sort of a J curve. That's what we say about our clerkship, is that you start out feeling confident and you hit this low point where you feel like you're not really learning anything well, and then you take off. And later, learning comes easier. This is like people, many of you here have learned more than one language from the time you were a tiny child. And what we know is people who learn 2 or even 3 languages, when they're acquiring languages, will learn any one language later than somebody like me who really only learned 1 language. But you catch up, and in 2 or 3 years, you're speaking at the same proficiency. But over time, you're better at learning languages. So that's a little bit of how it works with the clerkship. And so longitudinal design allows for this key repetition, spaced learning, and integrated design allows for interleaving. So we're now on the part of the talk where I'll describe our clerkship, which is now in its 17th year. I can't believe it. But we spent a whole year before we started really planning and thinking about what are the principles that we want to design this clerkship around. And of course, there are many different ways to give life to principles. Of course, they're within constraints that the medical school gives us, outcomes that the medical school really needs to see to allow what was at that time a pilot to move forward. Um, and that was a very meaningful process to all of us. And even 17 years later, when we need to make curricular revisions, we ask ourselves, are we true to our founding principles? And some of them are that the clerkship needs to be relationship-based, relationships with patients, with faculty mentors, with the institution as a whole. It needs to be developmental. And we really can, because it's longitudinal and because faculty know their students. This is largely outpatient based, so they have faculty in each of the major disciplines, and they follow these patients over time. You can really gear the clerkship developmentally, so you do simpler things at the beginning and then make it more complex. To the point where students can really go in by the end of the year. They can see a patient, take a history, formulate a differential diagnosis, and make a plan. What I say to them at the end of the year is, that's what being a doctor is. You can get better at it, but they really learn developmentally. With block rotations that are sort of inpatient-based, if you do internal medicine first or sixth, you're pretty much going to do the same thing, right? And you still learn, but it's very harder to gear to the learner's sort of needs. And we talked before about longitudinal integrated, and we call all these principles of educational continuity of care for patients, learning through patients, of curriculum, and also of supervision. I know this is a busy slide, but you have the reference down at the bottom. So how does it look? This is just a schematic of typical block rotations. I know there are more subjects, but just for simplicity, we have these 4. And what we do in a longitudinal integrated model is we kind of turn them on their sides and we stretch them out. And then we smear them. I don't know how to smear on PowerPoint, but you get the idea. Now I'll show you a typical student schedule. A typical student experience in one clerkship. So this is an internal medicine clerkship, which might happen one afternoon a week with a dedicated preceptor, and they sort of compile or construct a cohort over time where patients have representative diagnoses. And you can be much more intentional about the types of patients and diagnoses that a student sees versus inpatient block rotations, where you're really dependent on who gets admitted. And it might be a specialty service like nephrology, and that may be most of what you see. So here's one patient with diabetes and peripheral vascular disease. The student may have met that patient in the emergency department, where they saw them in an undifferentiated state, and then they were diagnosed and admitted to the inpatient unit. The student followed them and then brought them into their own outpatient clinic. There might have been a couple of more inpatient admissions for that patient over time, in between which the student would see them in the outpatient clinic, and during their inpatient stays, the students would round on them and maybe accompany them to tests and procedures. Another patient with chronic lung disease, another patient that was picked up inpatient with a stroke, a patient with headaches who maybe needs to go see the neurologist, and then the student would try to go to that visit as well. And you can see just the way we can help students get a breadth of experience. They follow patients through all different venues of care, including making home visits, and then they interact with other faculty and consultants beyond the primary preceptor. Boy, I don't want to overwhelm you, but this is a typical student schedule. As you see, they have the core clinics. You can see in the morning, neurology and OBGYN. 4 days a week, they have core clinics. And they may have more than one here I think Thursday they have medicine and psychiatry. You can kind of read what else they have, including a weekly tutorial and on topics related to patient care that start more simply and get more complex. And I lead a reflective practice group with them called the Developing Physician, which is really an opportunity to discuss the process of professional identity formation. In this longitudinal white space, students can choose what to do. They may choose to follow their patients to a specialty appointment. They may choose to read or even rest. They have a lot of self-directed learning. And we'll go on. And I want to give you a sense of what this clerkship feels like to a student. And I want to mention that Dante Foster was in our very first group of CIC students. She's now the chief of surgery at a hospital in Alaska where she grew up. And she decided to make this audio recording after she went to a party with traditional medical students, and they were talking about patients in very reductionistic ways, like body, as if they were just body parts. So here we go.
Florence is a friend of mine. She's also an avid bingo player, mother, and retired medical assistant who's been hospitalized 11 times in as many months. She is an 83-year-old woman with diabetes, hypertension, and severe peripheral vascular disease who I met at her internist, Dr. Lacey's office, last July. I was a brand new third-year medical student. She was struggling to breathe against 30 pounds of extra fluid. When Dr. Lacey told her that she needed to be admitted, she shook her head and said, "I'm a worker, not a patient." Florence is a friend of mine, and she's feisty. Florence is a friend of mine. Since July, Florence has weathered hospitalizations for CHF, cellulitis, osteomyelitis, TIA, stroke, peripheral revascularization, transmetatarsal amputation, anemia, urosepsis, and an upper GI bleed. Dr. Lacey tells me that if I understand Florence, I understand all of medicine. As her student, I have crossed venues and disciplines, from cardiology to infectious disease, neurology, vascular surgery, podiatry, hematology, nephrology, and gastroenterology. She has kept me running between the library, clinics, wards, and operating rooms since the day we met. As a student in the integrated clerkship, I've had the privilege of following Florence through her medical journey and the opportunity to give back. In November, I was paged to the ER where Florence had presented with 1 day of right-sided weakness and slurred speech. I was able to tell the attending that her marked facial droop was due to an old Bell's palsy. After a brief conversation with Florence, I was also able to tell him that she had developed a new Broca's aphasia. As a student, the extent of Florence's influence is coming clear. I've heard traditional third-year students describe their horror at the sight and smell of necrotic feet in vascular clinic, but it has never occurred to me to be disgusted by Florence. I remember seeing the first signs of an ulcer on her toe. I was there when erythema gave way to necrosis and osteomyelitis. But it was all happening to my friend, Florence. So when it was time to amputate her forefoot, I just wanted to do right by her, to find vital tissue. You see, Florence is a real woman, with real troubles, joys, and fears. When her wounds need tending, I tend them. I don't worry about whether they're gruesome or hopeless. The integrated clerkship has taught me to focus on the tasks for which I came to medical school, to serve the person with and beyond the disease.
So that's a little bit of the experience of a student. One thing she didn't talk a lot about is sort of outside advocacy opportunities and experiences which students have with many of their patients. And you also heard there that this student was kind of the continuity through this patient's journey. She was able to tell the ED attending what was old in the neurologic findings and what was new. And you can debate whether that should be the role of a medical student, whether they should sort of fill gaps in the system, but that often ends up happening. So some of the outcomes we sort of planned the CIC as an intervention, and we studied the first 3 years. including with a comparison group. I'll run pretty quickly through this, but we had 27 students, CIC students over the first 3 years, and we oversampled the comparison group, most of whom had signed up for the clerkship but didn't get it. So it was a pretty good comparison. We select students by lottery. There were no differences that we could detect between the intervention group and the comparison group. And we were really interested, did we actually build the program we intended? Was it longitudinal, faculty taught? How close did they get to their patients? So here are some of our outcomes. And we wondered about the longitudinality. So how often have you been involved in seeing patients you have treated before their initial diagnosis and the decision to admit? And 70% of our students were involved very often or often. And you can see the numbers for the comparison group. Seeing patients after you've treated them inpatient in some capacity, almost 90% of our students have. Involved in establishing relationships with patients that you would term as meaningful, 100% very often and often for our students. Making a real difference in the health or well-being of your patients, over 80% of our students very often or often. They do very well on traditional exams, better in some subjects, and on our OSCE. That was a condition of going on with a clerkship. They had to do the same or better than traditional medical students. And these are just some stats. You got to believe me because I know we have a short amount of time. And we asked the students their experience of the clerkship. And they didn't say that it was easy. I mean, some students, a minority of them, but in the beginning they would come to us because they didn't want to go to the Mass General and experience what they saw as a really challenging clinical year, and they thought it would be easier in this mission-driven community hospital. But in fact, they found it, and the stars indicate statistical significance, more hectic, more stressful, less boring, more satisfying, more humanizing, more rewarding, less marginalizing, more confidence building, and more transformative. So it isn't because it's easy, it's actually more challenging, but it's also more rewarding. They felt more prepared on all these measures, to be self-reflective, to have the knowledge base, to be a competent physician, to tolerate ambiguity, to understand how the healthcare system works, to be truly caring with patients, to deal with ethical dilemmas, to see how the social context affects patients, to involve patients in decision-making, and to relate well to a diverse patient population. At the beginning of the year, as I said, there were no differences on any of our measures, including the patient practitioner orientation scale, which is a measure of patient-centeredness. There was no difference initially on this scale, but our students gained ground over the year, and the other students, a comparison group, actually did what is typical and lost ground in their patient-centeredness over the year. But what was really important is that we followed them over time, and 4 to 6 years later, we learned that our students retained their patient-centeredness, even though they went through residency, and many of them were attendings, and the comparison group stayed exactly the same as well. It's like railroad tracks. And so we hypothesized that maybe there's something about that clerkship year that immunizes them against ethical erosion, or at least diminishment of patient-centeredness. We also found in a qualitative study that students reported that this is a very relational clerkship, and in fact, their memory and their knowledge of medicine is linked to remembering individual patients. They know about diabetes because Mr. Smith, who they cared about, had it. And they remember his treatment, and they remember the issues that he went through. They also really felt that we engaged with them as unique people and encouraged them to somehow integrate their pre-professional identities with their professional identity in ways that they maintained an authentic sense of self as they grew into the doctor role. Lots of support for learner autonomy and discovering meaningful roles, and that in fact could mean visiting a patient at home and taking public transportation to their doctor's appointment or advocating for change at a larger level policy. They really would be motivated to find a variety of ways that may be non-traditional to develop meaningful roles, and that we really made our values explicit and tried to live them. Finally, some of our challenges and lessons learned. Um, this is a paper that mentions three particular challenges. The first is boundaries. If you take a group of save the world motivated students and you put them with patients and they get to know those patients, there are going to be common boundary issues, like a mother of a pediatric patient says, well, you are going to come to my child's second birthday party, are you? Or we've even had older patients trying to fix up the medical students with their relatives or children. And you have to learn, how do you respond in a way that doesn't shame the patient but maintains a professional boundary? Defining the appropriate scope of the student role. How expansive is it? How narrowly focused on biomedicine is it? We really had to think about that. Did we really want the students sitting in waiting rooms with patients for 2 hours waiting for the specialist to come? Is that a good use of their time or not? And then finally, and this is a very challenging thing, the students had a lot of autonomy in managing and negotiating the learning agenda. And sometimes there were conflicts, like the surgeon would say, please come and scrub in on your patient who I'm doing a procedure on. The medicine preceptor might say, you have to come to clinic and see your homeless patient. And they were at the same time. So you really have to learn how to articulate your own learning goals in a way that doesn't put off your faculty. Some of the lessons we learned: that the students' motivation to learn medicine derived from a profound sense of duty to serve their patients. And that my faculty colleagues, all of us, say it's deeply satisfying for faculty to teach relationally. I have a colleague who said, I never had a meal with a block student, but I've never not had a meal with a CIC student. And finally, that our educational change has both responded to and has driven systems change. So some of the things that we've implemented with the students, because they walk in the patient's footsteps, they see the gaps in our system as they cross venues of care. And so we've been able to really change things based on their insights. And some of our learning and innovation from undergraduate medical education is used to improve GME in practice. For example, we came up with a beeper system where students can be alerted every time their patients enter the hospital through some door. So it could be to the emergency department, it could be checking in with a specialist, and they can, if they have time, go and greet the patient there. They can turn their beeper to different settings, so it's not required 24/7. The one thing that is delivering a longitudinal patient's baby, which is incredibly gratifying, and which they then can follow the baby in pediatrics clinic and the mother postpartum. And then this is a growing movement really internationally. We have a consortium called the Consortium of Longitudinal Integrated Clerkships, and they have annual conferences. We have a book about longitudinal integrated clerkships, and every chapter is written by experienced faculty and sometimes students, and the chapters are co-taught because we really want cross-institutional experiences with case studies. So I think that's pretty much what we have for today. Feel free to contact me. Don't use Twitter. I learned it a while ago, but I don't really know how to use it. But there's my email address, and I'm very happy to answer any questions whenever we have the question and answer time. Thanks so much for listening.